Thank you everybody for getting on the line. So we're going to have a great presentation talking about overhead throwing, injury prevention and treatment. And just to give you a little overview of what I'm going to talk about, and my talk's going to be brief. It's just going to be some shoulder anatomy, so you have some background, a little bit about throwing mechanics, some specific shoulder injuries that we see in throwers, and then talk a little bit about treatment and prevention. And I think that really a lot of the bulk of what we're going to talk about tonight is going to be from Ryan and Brian, who are going to be able to give some specific rehab pearls and exercises for prevention and treatment of some of these injuries. And even though we're predominantly talking about baseball, when we look at overhead throwing, really this includes overhead throwers in other areas, whether it's football, other overhead athletes such as volleyball, and softball. So this is not exclusive to baseball. So when we look at the shoulder anatomy, first of all, basically three major bones of the shoulder: the scapula, the clavicle, the collarbone, and the humerus. And they really provide a very complex series of movements in the upper extremity. So if you look at the coordination between the humerus as well as the scapula and the clavicle, and this is just demonstrating reaching up overhead, it's not even throwing, you can see that there's intricate movement that occurs between these bones, and that's really what the job of the muscles, the tendons, and the ligaments around the shoulder. And that's why these things are so susceptible to injury if this movement is not extremely precise. So when we think about the superficial anatomy, that's the part that a lot of people are familiar with. There's the deltoid muscle, the pec muscle. These are, what we like to call the beach muscles. And these are what a lot of people work on when they think about strength training. And they're actually less likely to get injured, but it's really the structures underneath that are much more common to be injured and are actually really much more important when we think about throwing mechanics. So the rotator cuff is underneath. This is looking at the front of the shoulder, and the subscapular, there's four muscles of the rotator cuff. The subscapularis is one of the tendons in the front. The biceps tendon, also the muscles down in the arm, but the tendon runs right through the front of the shoulder. And then the remainder of the rotator cuff includes three other muscles: the supraspinatus, infraspinatus, and teres minor. And these are called a cuff because they all are a confluence around the humerus. But they're really important for providing stability to the shoulder when we go up overhead. Then there's also the labrum and the ligaments. Underneath that is what we call the capsule, and that includes ligaments that help stabilize the shoulder because the shoulder is inherently unstable because it's like a golf ball on a really small tee because of the shape of the humerus and the glenoid, the socket. And then in addition, those ligaments attach to what's called the labrum, which is the cartilage ring. So this is a picture of the labrum underneath. So again, that circles the entire glenoid and shoulder joint and is susceptible to injury as well. And then finally, there's a lot of muscles that power the scapula, the shoulder blade. And as you'll hear from our rehab specialists from NovaCare, I mean, these can be really important in throwing mechanics and can really be one of the things that naturally people aren't concentrating on, but it's probably the most important for making sure that you have the appropriate mechanics and don't make the rest of the shoulder joints susceptible. So that includes your trapezius and your rhomboids and your levator scapulae and all these muscles that help power the scapular shoulder blade. So the phases of throwing have been described really for almost 50 years at this point. And when we think about this, we go from wind up, early cocking, late cocking, acceleration, and follow through. As we understand these mechanics, we really know that there are predictable forces that are seen at both the shoulder and elbow. And because of that, it really helps us to both identify injury patterns and also to prevent them. And the majority of injuries we see are either at late cocking or occur through follow through. And one of the things that I think, again, my rehab colleagues are going to touch on is this idea of the kinetic chain. So it's really this energy to get that ball to, go at 100 miles per hour is fueled really from the legs and your trunk rotation, and then these small upper extremity segments till you get to the point of contact with the ball. And it's really crucial, and that's what creates the appropriate mechanics and prevents injury. And that's why things like core strengthening and leg strengthening and hip strengthening are so crucial to proper throwing mechanics, because it's really not about throwing from the arm. So when we think about these excessive forces that occur, again, there's really high angular velocities, really up to 7,200 degrees a second as you're going from late cocking into acceleration. And you also have extreme and external rotation is what makes a great pitcher great, but it's really hyperpathologic, and not something that the shoulder is designed to do. And then also, when you release the ball and you're decelerating, there's a significant distraction force at the glenohumeral joint. And those posterior muscles, the scapula and the back of the rotator cuff, they really have to counteract that. And that's also why strengthening these muscles is so crucial to prevent injury. And also, one of the places that we initially see injuries in throwing. So there's kind of this pathologic cascade, unfortunately, that we see in throwers, where we have muscle weakness and scapular problems, and then it increases the external rotation and hyperangulation. They get micro trauma. The back of the shoulder, what's called the posterior capsule, contracts, and if we don't counteract that, then they start to run into all these problems that occur and we see in shoulder injuries, including impingement, rotator cuff tears, or superior labral tears. You can have subluxation, where the shoulder partially pops out of the joint, and instability. So these kind of run in a circle, and unfortunately, until you interrupt this cascade, it continues to occur. So the point of this slide isn't to go over all these different things that can occur to the throwing shoulder, but it's really to point out that there's a lot of things that can go wrong in this process. And a lot of them are interrelated, and a lot of them can be treated in a similar fashion, especially when we talk about rehab. But certainly, if a thrower's having shoulder pain, knowing what's causing the problem is important to really help direct their therapy program to try to improve their outcome. The other thing, I'm not sure if again, Brian and Ryan are going to talk much about the elbow, but it's important to understand that the same forces we're talking about placing on the shoulder also get placed on the elbow in that extreme of external rotation and valgus on the elbow. So that makes that susceptible to ulnar collateral ligament injuries, which many people are familiar with because of the Tommy John surgery. You can get flexor pronator tendinitis, a posterior impingement about the elbow in that position, stress fractures, ulnar nerve symptoms. So all these things are also true about the elbow, and again, is why it's important to strengthen the entire kinetic chain to protect the elbow. So I'm just going to touch very briefly on a few of these common throwing injuries, including slap tears, biceps tendinitis, rotator cuff tendinitis, something called internal impingement, instability, glenohumeral internal rotation deficit, and scapular dysfunction. Don't worry, they're going to get one slide each, so it won't be long because we're going to keep on time. And I think the most important thing is that nonoperative treatment is really the mainstay of what we do for nearly all these problems initially. So that includes some activity modification, ice and anti-inflammatories. And I mean, this physical therapy, I was thinking about this as I was putting this lecture together. And, my friends from NovaCare are actually really pretty smart, because if they wanted to put together a topic where therapy was like most crucial for prevention, treatment, and post-op rehab. I mean, overhead throwing is probably the number one thing. So, they're no dummies. They know how important this is in this process, and it's just true. So, and that's what they're going to talk about. But it really is the way we treat the majority of these things, and it doesn't matter if you're a 12-year-old thrower who's having shoulder pain or you play for the Phillies. That's what they're doing, because surgery that I do is kind of a last resort. Cortisone injections can be used. I mentioned that. I mean, again, that's more for our older athletes. Certainly, I'm not sure who's in the audience, but we really wouldn't consider that in our teenagers and younger athletes. But sometimes we do it for older athletes to try and calm down inflammation. And then there's always change of position or sport. And obviously, a professional athlete's not usually going to do that. But sometimes we do that with our high school athletes to try to minimize the stress that they're putting on their joint that's injured. So superior labral tears. So the labrum, again, is the cartilage ring that sits inside the shoulder, and the superior labrum's on top where the biceps attaches. And it can be injured commonly in throwers. And there's a couple of different ways it gets injured. There's, traction and follow through. There's something we call peel back, which is as they go into that abducted and externally rotated position, the labrum can get peeled back off of the socket. So there's a variety of ways that this happens. Again, this is initially treated with therapy. There are times that this requires surgery, but usually when an overhead thrower comes in with this injury, even though they come in and say, I tore my labrum, this must need surgery, we usually try to rehab those patients. And a lot of times it's focusing on all these other areas, as I mentioned, of the kinetic chain, the scapula, and the trunk. Biceps tendinitis, with repetitive throwing, the biceps, which runs right through the front of the shoulder, can get irritated, and you can get tendinitis or sometimes get biceps tendon tearing. Once again, this is something that's almost always treated with therapy, modalities, and strengthening of the muscles around the shoulder to take stress off of that area. Rotator cuff tendinitis or tears. As you overwork that rotator cuff, because it's really providing a lot of that stability, you can get fraying of the rotator cuff, and eventually you can get partial thickness or even full thickness tears. I most commonly see rotator cuff tears in overhead athletes, workers. It's not necessarily throwers, but this can be a common injury after repetitive trauma. I also should mention, this is something I never see in 12-year-olds in general. This is something that's really more the older athlete. If you're a 25-year-old, 30-year-old baseball pitcher who's been doing it for an extended period of time, you're much more likely to get this injury. There's something called internal impingement, which is basically that when you're in that extreme externally rotated position, part of the humerus bone, the greater tuberosity, pinches the rotator cuff or the labrum in the back of the shoulder. And that can cause partial tearing of that area of the rotator cuff and can cause posterior shoulder pain in those athletes. So it's, again, another source of posterior shoulder pain, and can many times be associated with some anterior laxity or instability. Shoulder instability we see for a variety of reasons. Most instability we see is more traumatic in nature. So I just saw a baseball player who dislocated their shoulder diving into a second base, and that's different. That we can see in almost any athlete, and they injure the ligaments and tear the labrum. But with repetitive throwing, you can get stretch of these ligaments, and they get loose, and then this can cause subluxation of the joint. Sometimes with throwers, or especially pitchers, they say that they have both pain and loss of velocity. And this is kind of the classic dead arm syndrome that a pitcher would complain of, where they get a subluxation episode and they feel this dead arm sensation. Glenohumeral internal rotation deficit, or GERD, is essentially that this excessive posterior shoulder force causes the ligaments in the back to tighten, and there's a restriction in motion and a loss of internal rotation. This is something we can usually pick up pretty easily on physical examination, And when you have this, it really puts that shoulder at risk for either rotator cuff or labral tears. And, one of the things that a lot of throwers know these days is the importance of what we call posterior capsular stretching, which is stretching the back of the shoulder, or something we call a sleeper stretch. And this is really crucial to prevent this internal rotation deficit, which then can lead to injuries of the shoulder. And then there's scapular dysfunction, or something we call the sick scapula. So the scapula really relies on this muscle support for proper movement, as we talked about before. And with repetitive use of these muscles, you can get weakness, and then you get improper shoulder movement and pain. And the scapula is really one of the major sources of improper shoulder function. And that's why a concentrated rehab program really works on these scapular muscles to try to treat and prevent further injury. So when we think about prevention, there's been a lot of study that's been done actually over the last 10 to 15 years, especially when we look at youth athletes, and about how much more common this stuff is getting in youth athletes, and how we're putting them at risk with overuse. So it's really, in the sports medicine societies, we've really started to look at, everything from pitch count to all the other things that put young athletes at risk. So I think it's important. I mean, if there's coaches in the audience, particularly of youth baseball, I think most of you are familiar with this, but this is, the recommendations for pitch counts in young athletes, and this is readily available. And it's really important to abide by this. And it goes by, age and number of pitches. So it's really important to make sure that we're not creating these overuse injuries and making our young athletes susceptible. This was just a study recently that was done that also showed that we're not necessarily doing this. And a lot of the youth coaches are either don't understand the importance of pitch counts, or not keeping track. So again, I just want to emphasize the importance for the youth coaches who are in our audience about making sure that you're paying attention to this issue. So, finally, basically, in conclusion for prevention, and again, we're going to get into the details of that in these next few lectures, but appropriate stretching, strengthening, which includes the entire kinetic chain, the rotator cuff, and the scapular stabilizers, really emphasizing good throwing mechanics, and appropriate rest when needed. And that's what's going to keep you, potentially out of being in my operating room with your shoulder, which certainly isn't where you want to be. And that's all I have as an overview on this. And then I'm not sure if I'm passing this on to Ryan or Brian next.
Yeah, I think I'll jump in, Dr. Freedman, and we'll pick it up with some of the rehab considerations. So I'll share my screen real quick. All right, so thank you everybody for having me on as well. Dr. Freedman touched on a lot of great points, which we'll just kind of expand on a little bit between Brian and myself. In terms of what I will be talking about, I'm going to be going into a little bit more of some of the risk factors for injury, some of the rehabilitation phases and highlights, a little bit of some throwing mechanics and the kinematic chain, as Dr. Freedman has kind of alluded to, touching on like a little bit of like a specific point there. What I don't want to do, and what I'm not going to do tonight, is get into some of the nuances of the specific exercises of physical therapy and a lot of the specific timelines. Mainly just thinking of, if there's parents, there's athletes, or there's coaches in the stands, want to give you guys something that you can really start taking home and start thinking about tonight, and really maybe even implement as early as tomorrow. So risk factors on it for injury, and Dr. Freedman did a great job of touching on a lot of these. Pitch volume is obviously the number one factor for us here, but I like to think of it as kind of like the two V's, right? So volume and velocity, right? So the old adage, or maybe the myth that's maybe been put to bed a little bit is when I was growing up, it was, are you throwing too many breaking balls? Are you starting breaking balls too early? And really what it's starting to come down to is velocity is a big key factor, and volume. right? So like I said, Dr. Freedman has kind of touched on this in terms of number of pitches per game. We're also looking at it over the course of a season and really over the course of a year, right? So especially they've studied this a lot, kind of like in the adolescence, and you know, Dr. Freedman put up that pitch count like per age, which is very well thought out. It's very accurate. The other thing that you guys really want to kind of look at is over the course of the year, there's a dramatic drop in injury risk if they're pitching 8 months out of the year or less, right? So if you're somebody who's playing year round, I would definitely recommend trying another position, probably other than catcher. And then same note, at the same season you're playing for 2 teams, I certainly wouldn't recommend pitching for both those teams within the same season. The other thing that they really look at, if you're somebody who tends to take a lot of warm-up pitches, right, that's another indication for another risk factor for a potential arm injury. When we're looking at velocity, there seems to just be a little bit of a threshold at that 85-mile-an-hour mark where you are throwing greater than that, you're 2.5 times more likely to end up with an arm injury that's going to require surgery, right? As opposed to somebody who's not throwing that hard. So it's a little bit of a double-edged sword for us, where obviously if you're throwing harder, right, the harder you're throwing, the more successful you probably are as a pitcher. But you're also going to be at a higher risk for injury, right? Where we need to probably pay a lot closer attention to the overall volume. Along with velocity, this details more or deals a little bit more with the elbow. But they took a look at the MLB and their professional pitchers, where they're seeing an increased risk or an increased incidence of Tommy John. And what they're kind of finding is those who throw a high number of max effort throws are at a higher increased risk for an elbow injury, and certainly can be in that category for shoulder injury as well, right? This is regardless of velocity, right? So if you're thinking you're somebody who's a little bit younger, maybe that freshman year of high school, we're not kind of ramping up to 85 miles an hour. If you're still throwing as hard as you can, a lot of the time you're at an increased risk for an injury. And you know, kind of what Dr. Freedman has talked on as well, range of motion and strength loss is certainly going to factor into that as well. Again, I think it's a little bit of what came first, like the chicken or the egg. You know, like are we seeing range of motion and strength loss because of this increased volume or these high amount of high effort throws? It's probably all kind of like feeding into itself. So some of the rehab highlights. So we're going to touch on range of motion, strength, and a little bit of the return throw progression. So range of motion, the big thing that everyone really kind of focuses on, that Dr. Freedman alluded to, is rotation, that being internal rotation and external rotation at the shoulder joint. When it comes to physical therapy, and we kind of look at on the rehab side of things, is we're looking really at this total arc of motion, right? And what we're really kind of finding is if you're somebody, especially if you're somebody who has a little bit more velocity behind it, so one of those guys who's throwing up in the 85 mile an hour or greater, you're going to start to see a little bit more of this external rotation, right? And resulting maybe a little bit less of this internal rotation, right? But this general arc is still going to be right around, I would say, 175 to 185 degrees, right? As opposed to this would be their non-throwing hand, where they have a little bit less external rotation. This is what we would probably see on somebody who's not an overhead athlete. We would see this bilaterally, right? So it's okay to see a little bit of this difference bilaterally, but I think what Dr. Freedman is alluding to, and really where we kind of get in trouble, is if we see this much external rotation, but then we're only seeing this little bit of internal rotation, right? And that's where it becomes a problem. And that's where we can really start to see some issues in terms of whether we're already at the point of an injury or we're heading towards the point of an injury. Some of the ones that I really pay close attention to that I think get a little bit overlooked, probably the second thing that I'm going to right off the bat is going to be flexion. So flexion just being how well we can reach straight up overhead. And one of the big limiting factors for this is going to be this latissimus dorsi, right, or our lat muscle, right? It's a good internal rotator for us, and it's responsible for producing a lot of the forces that help to make a successful pitcher successful, right? So if we think of one of the best pitchers in the game right now, Jake DeGrom, right? My guess would be they just keep saying right-sided tightness, right? That right lat might be a big problem for it, or is oblique, right? But again, if we're coming in and we're seeing less than, definitely if we're seeing less than the opposite side or less than 180 degrees, that's something that I'm going to be working on right away. All right, same can be said with the abduction and adduction motions. Horizontal adduction, we're going to see an increased risk for injury if there's a greater than 15-degree difference side to side, right? That motion just being when we're reaching across our body. Scapular positioning, Dr. Freedman kind of touched on, I'm not going to spend too much time on that. The other thing that I really look for is going to be our athlete's thoracic mobility, right? The thoracic spine being right in that middle section, right? When we get into the pitching mechanics, we'll kind of see the importance of that. But all of my athletes, when they're coming to me, they're getting assessed for it, like how well they can kind of extend through that thoracic spine, and certainly how well they can rotate through it. And we'll kind of highlight the importance of that in a little bit. When we get into the strength phase, right? So I call this kind of like the intermediate phase of the rehab program. Starting out, we're still trying to maintain that flexibility that we've gained in the early phase. It's just going to be some progressive strengthening of the rotator cuff muscle, the scapular musculature. We're trying to develop some neuromuscular control, develop some stability, things like that, and see if we can get them to this advanced strengthening phase, which at that point, we're thinking a lot more of like the compound lifts, right? So like the back squat, trying to strengthen here, trying to strengthen the core, strengthen the legs, right? Strengthen the shoulders, right? We're thinking, some back squatting, some lunges, some dumbbell pressing, some overhead pressing, whatever it may be, right? Dr. Freedman, again, he alluded to all the forces that kind of go into the throwing motion, right? And that's really what we're trying to do. We're trying to bridge that gap and make this athlete successful when we initiate them with an interval throwing program, right? So I think this diagram does a good job of just kind of showing just how many forces are going through the joint. This is if we're looking at about like a 90-mile-an-hour fastball. If we just isolate out the elbow, right, 90-mile-an-hour fastball, we're getting 64 newtons of force kind of through that elbow. We know that the UCL or the ligament that's involved in that Tommy John surgery, we know that can handle upwards of about like 30 newtons, right? So we have to be strong in a lot of other areas to overcome that other 30 newtons of force to kind of make sure that we're successful in kind of preventing some of those injuries. So the overall return to throw or return to participation, right? So when is this appropriate with an injured athlete? I look at a few things. If we're looking at someone that I'm just conservatively rehabbing, I'm looking at a little bit of a timeline where we kind of have their pain under control. We've restored their range of motion. We've restored their strength. When it comes post-operatively, I'm leaning a little bit more on, the Dr. Freedmans of the world, because there is going to be a timeline associated with appropriate healing. And then still kind of looking for those other keystones, right? So we want that range of motion full. We want the strength to be restored. We want them to be able to handle a few like plyometric things, like some tossing into the trampoline, things of that nature. I don't get super hung up on it, because I do think that in general, the throwing program itself is going to be a strengthening process as well, right? So the throwing program is going to be a bridge between our end stage rehab and our overall return to a game situation, right? So long duration, this is going to take like weeks to months. This is usually post-operatively, right? Short duration can be a couple of weeks, depending. This is something we'll see if, we had to shut a guy down for 2 weeks. There's still 8 weeks left in the season. He's our Saturday guy. We got to get him going. This one that I like to use is usually about 3 weeks, right? But again, we're not just going to send them back out there, because if we do so, we run the risk of kind of putting them in this danger zone, right? So I really like this graph more so in terms of like an injury prevention standpoint. So one of the things that I do think in the sport of baseball, where, especially maybe in the earlier stages, like the middle school, high school areas, and I think it's really difficult to get somebody on a consistent throwing program. But I'm a huge advocate for strengthening the arm by throwing, right? So these are some guys over in Australia, and they've essentially developed an acute on chronic workload ratio. Essentially what they've done, they've looked at, rugby players, they've looked at cricket players. And if we look at the cricket players in individually in terms of how that relates to baseball, is they've kind of found that high levels of throwing can actually decrease our risk of injury, as long as the ramp up to get to those high levels was gradual enough, right? So if we're going along a nice throwing program leading up to the season, say over the course of like 8 weeks, and we're really getting our athletes ready to handle the workload of a season, our chance for injury is way lower than if we're throwing, 15 to 20 pitch bullpens. And then the next week, this guy's going out and he's throwing 80 pitches in his first game, right? That's where we kind of have that huge spike in workload, and we're entering this danger zone where it becomes a little bit more apparent, a little bit more easily susceptible to injury. Anytime we talk about throwing programs, the hot button topic that I get asked a lot about today is a weighted ball program. Is it worth it? Is the juice worth the squeeze? Does it work? The research that really comes out about this is it will indeed increase your velocity. It's also, going through one of these is going to increase your chance of injury, right? So Mike Reinhold is a big name in my world, and he kind of took about 40 baseball players at the professional elite level, took them through a weighted ball program. Their velocity went up, but also 24% of his cohort experienced some form of upper extremity injury. Right. So a lot of the other research out there looks at, does it increase velocity, which it does. I mean, that's pretty consistent through the research, but we're also running, you have the potential of, a 25% chance of injuring that arm if you're doing so. So if you're somebody who really wants to give this a try, I would recommend doing it under strict supervision. And as soon as we see any alteration in any of your throwing mechanics, I would shut it down for the day. Touching lightly on the pitching mechanics, right? So Dr. Freedman kind of went through the phases of pitching mechanics, and really where we're kind of seeing the injury really developing in that late cocking and that follow through phase. What we're going to kind of focus on today is what kind of leads us right up until that point, which is that foot down, right? Or that 4-foot strike, and really where we want our body to be in terms of how we can appropriately utilize our kinetic chain to help kind of prevent injuries for us, right? So at foot strike, right? So as soon as this foot is hitting the ground, where do we want our athlete to be? We're really looking for, number one, foot facing towards home plate, right? That's going to allow us to open up these hips, right? And then we're taking a look at where these hips are. We want this belt buckle pointing towards the target as well. And we want our shoulders back, right? So we refer to this as hip shoulder separation, right? And that's going to allow that nice transfer of forces all the way up into the arm. And it's just going to allow it to do it at appropriate levels. And kind of what Dr. Freedman alluded to, I like to say, like, the arm's almost along for the ride, right? And at this point, if we're doing things correctly, this arm is going to be, that elbow is going to be at right around a 90-degree angle, right? Shoulder is going to be flexed again at about 90 degrees. Right. If we are a right-handed pitcher, optimally, that ball is going to be facing kind of the third base side. If we're a left-handed pitcher, facing the first base side. Again, these are, and when we kind of look at this really just kind of sets us up for success in terms of allowing that kinetic chain to just flow as smoothly as possible. Right. Conversely, right. So if we're somebody who gets our foot down too early, right, or we separate our hands a little bit too early, we kind of end up in this position. This is like kind of like the fatal flaw of pitching mechanics, right? So this is Mark Pryor. When Mark Pryor came out of college, he was known as, the guy with picture perfect mechanics. Ran into a ton of arm injuries, and you can kind of see why here, right? So his foot's getting down, belt buckle and shoulders are exactly the same, right? He has no separation. He has no potential energy buildup, and his arm is not really in a position to kind of just be along for the ride, right? All these forces are just going to kind of end right up on the shoulder and the elbow for this guy, right? And it just kind of shows for people that have kind of thrown with these mechanics, like Steven Strasburg, like I said, the Mark Pryors, the Kerry Woods, these guys have kind of ended up with multiple injuries, both shoulder and elbow, right? And in terms of like the research, they've really kind of identified this point, and they've kind of seen like, all right, here are these guys who have had really long, successful careers and really haven't run into a whole lot of injuries. And what I find interesting about it is, these guys have very different ways of getting to this point, right? So if we think like Randy Johnson has a way different way of getting there from Greg Maddux, right? But when that foot's down, these guys are in the same exact spot, right? Very little injuries between the two throughout the course of their career. I think the picture perfect example of this is going to be like Nolan Ryan. So he was considered to have the golden arm, right? Throwing 104 miles an hour from when he first came up in the league, had a 20-year career, 20-plus career league or career, and he's just maintained those mechanics throughout, right? This is a great example of how far over he's getting that foot, right? So if we draw a line straight from where his plant foot is, right, he's laying on the opposite side, and that's a really good indication of how he can open up those hips, right? And that's just a picture of him showing off still today. So if we take a look at what this looks like really quick, if this video will play for me, as much as I hate putting this guy up here because of the uniform that he's got on, he's probably the best in the game at this point. And here's why, right? So we're going to try and stop this guy like right as this foot comes down, super slow motion. And you can really just kind of see foot comes across. And as he lands, oh, if we back this guy up a little bit here, a little far. As he comes through, oh, sorry guys. Try this one more time. And that's kind of what it looks like in real time. Again, really getting this foot facing right towards home plate. We can see his belt buckle. Thank goodness we can't see the logo on the front of his shirt. And he's just in that 90-degree position. And that's really one of the things that helps to make him really successful. And up until very recently, avoids injury a lot of the time. So some of the take-home points for me in that presentation, in terms of injury risk, we're really looking at the two V's, velocity and volume. We're thinking, when we do have an injury, we're taking a look at range of motion before strength, although both are probably equally important. I think you want to throw strategically to strengthen the arm and help to prevent some of those potential injuries. And in terms of the pitching mechanics, that can be very nuanced. There's a lot that kind of goes into it. I took a look at a very specific point, but I do think that 4-foot strike can be a checkpoint for everybody in terms of just helping to reduce that injury risk a little bit. So that is all I have for you guys on my end. I will turn it over to Brian here. I'll stop sharing my screen. Brian, you can take it away, my man.
Okay, I'm going to start sharing this. Get this out of my way. Okay, what's going on, everybody? Just to reiterate, I'm Brian Hanna. I'm the assistant athletic trainer for the University of Sciences, and I'm also their head strength conditioning coach. My blended position has really been successful here for what we wanted to do. They had a lot of, particularly with the baseball team, injuries. And what I was able to do is come in and really work on through strength and conditioning, our training sessions, prevention methods that we can do. So we established an arm care program that was very successful in the first 2 years. And I'm just going to go through that with everyone. So my lecture breakdown, I'm going to touch up on some of the common minor injuries that I see throughout the course of the season, the interventions that we do for them. And then I'm going to break down some prevention and arm care. I'll get into some strength conditioning stuff and with core training as well. So some of the common minor injuries, these were already touched on with everyone else, but bicep tendinitis and rotator cuff impingement, scapular dyskinesis, and GERD, glenohumeral internal rotation disorder. So in maybe a 10-week season, I'm treating at least 2 of these probably once a week with a different athlete. Very common, very easy to treat when you can get out ahead of it. I'm going to work in backwards order. So glenohumeral internal rotation disorder, usually just we've been touching on it all night, and that's because of how prevalent and important it is and how reoccurring it is in the overhead athlete. But it's just condition resulting in the loss of internal rotation. You can see on the picture on the left, you have that full rotation arc, external internal rotation arc that everyone touched upon tonight already. And then on the right, you can see that decreased rotation. This is usually due to inflexibility in that posterior capsule and our dorsal rotator cuff muscles. So what we can do for that, and this picture will be familiar from Dr. Freedman's presentation, but the sleeper stretch should really be the bread and butter of any overhead athlete. This is the position you want to get in. You typically want to get your weight over top of that shoulder and then work on getting adding internal rotation with the stretch. If you haven't done the stretch before and you try to do it as an overhead athlete, you're not going to get your hand to the ground. You don't want to cheat and have that shoulder up here raise up off the floor at all. You really just want to try to get as far as you can, feel that stretch, hold it for 30 seconds, 5 times a day. For the overhead athlete, this should be something we do when we wake up in the morning, before we go to sleep, and after any kind of training that we do with that sport. A posterior capsule stretch that we like to do, this picture down here in the bottom right, it's really just kind of reaching across and pulling that elbow to the opposite side. And then what we like to do also is instrument-assisted soft tissue mobilization, whereas people usually call it just Graston, but that's just because of the company that makes the tool. It could be anything with a beveled edge. I've even used like the end of a butter knife, not the serrated edge, obviously, but the other side of a butter knife. Really, in that posterior capsule, you can get some stubborn adhesions that you can't really get out with just stretching. And you kind of just like scrape away some of that, those stubborn adhesions. And it's very effective in combination with the posterior capsule stretch. Scapular dyskinesis, it's really just an alteration or deviation from your natural scapular movement. There are a lot of different variations with scapular dyskinesis, but I thought this picture kind of highlighted the 3 major ones that we see. In this picture here on the left, that inferior angle of the scapula is really protruding. In the middle picture, that full medial border is protruding out. And on this picture on the right, you can see that superior angle of the scapula is what's protruding out. So what can we really do for that? We really need to identify what muscles are overactive, what muscles are underactive, and strengthen the force couples surrounding that scapula. So this picture on the left, you can kind of see that dynamic, the total dynamic stabilization of the scapula. There's not much ligamentous attachment of the scapula to any other bones in the body. It's mostly held and controlled by all the dynamic musculature. If you look at this picture here on the right, you can see all that the force vectors that each and every muscle is pulling the scapula from. All right, so if we go back to this picture here with that inferior border is protruding, most likely we're going to think that that serratus anterior isn't really activated that much. All right, the upper traps are a little tight, and that scapula is being, posteriorly tilted a little bit. So what can we really do? So every individual case is different with scapular dyskinesis. Some of the most common deficiencies that we see are the overactive upper trapezius. A lot of people tend to hold a lot of stress in their upper traps. Everyone likes to go to the gym and do, shrugs, things like that. So that tends to be one of the most common overactive muscles. Inflexible wise, we see the lats to be very tight. The serratus anterior tends to be very tight, and our pec major tends to be very tight. Again, everyone likes to go to the gym and get on the bench press, and we don't do as much pec flexibility, so our pec is tight. Underactive muscles wise, and this is what we usually target with our strength exercises in rehab, those are lower trapezius, our rhomboids, and our serratus anterior. So as far as scapular stabilization exercises go, I's, T's, and Y's are pretty much the main exercise that people utilize. And also it's very easy to do without much equipment. So these are 4 different positions. This one's more of a W, but really what you're trying to do is pinch those shoulder blades together while you go through these I's, T's, Y's, and W motions. And prone 7s is something that we adapted from this for our specific arm care program. And that's where you're holding these positions, maybe with 3-pound dumbbells, or 5-pound plates, something like that, for 7 seconds each position. That's going to train these muscles, your rhomboids, traps, serratus, or your lower traps and rhomboids, more isometrically, because they need to, you need to have that longer isometric contraction during your activity. On the right is a serratus anterior exercise called the push-up plus. As you can see, they're just in a push-up plank position. The arms are completely extended, and the chest is going to be a bit lower than neutral. Right? And then to do the push-up plus, you're just going to protract your chest completely. So if you can see, the arms stay extended both times, but if you look at the trunk level is what's changing. So that's a really good serratus anterior exercise. Again, doesn't need any equipment, and it's easy to do. Flexibility-wise, so this top chart right here is a simple pec release. So on the top left, you can see right here, they're using probably a lacrosse ball or a baseball, but you're really just trying to get direct pressure right into the muscle belly of that pec. Usually about 20 to 30 seconds of direct pressure, and then you can start to get into some stretching. So right here, this guy's on a foam roller. and using a 5-pound chip to kind of just help stretch the pec, or you can even use something as like a door frame to stretch the pec out. The bottom left is a lat stretch. The main things, your arm is going to be completely extended and the thumbs are going to be pointed upward. And at the bottom right is just a simple upper trapezius stretch that you can do. Bicep tendinitis, very common injury that I see. I think I've treated it maybe 7 times this year. It's usually caused by just continuous and repetitive overhead motions. It's inflammation of the long head of the bicep muscle. And you're just going to present with aching and tenderness right in the front of the shoulder. There's a picture of the anatomy of it. So that long head of the bicep tendon just comes right up here in this bicipital groove. And usually the pain is going to be right in between these 2 lines, right where that 2 is. Mostly what you want to do with this is just take some time off and ice the area consistently. If someone comes to me and says, hey, my shoulder starts hurting, it's just started hurting today, and we look at it and it seems to be bicep tendinitis, yeah, we're just going to ice it right away. But typically it doesn't go that way. They're going to come to me and they're going to say, my shoulder has been hurting for 2 weeks. What do I do? I'm going to evaluate it. I'm going to say, look, it's bicep tendinitis. And what I've been doing recently is a friction massage. So you can see him use this doctor right here using it with his fingers. I'll just use my thumb typically, and I'll just go across this tendon for about 30 seconds. I'll apply some pressure. It's not going to feel very good. But what we're doing is we're restarting that inflammatory process of the body. Typically, it only lasts about 48 hours, and then it moves on to the next phase of the inflammatory process. So that cross-friction massage really kind of jump starts the inflammatory process, and then we can properly care for it with ice, anti-inflammatories, and then we'll get into more of the rehab. So bicep flexibility, this is a good bicep stretch that you can do on your own. We do our own stretches with the patients ourselves, but if you're doing it on your own, this is a great stretch to do for yourself. And then we're going to want to strengthen that bicep concentrically and eccentrically. This is one of my favorite bicep exercises for bicep rehab because your arm is abducted 90 degrees, and we're going to train the bicep in that abducted position, and that's typically where we are as an overhead athlete. When I talk about eccentric strength, this is a concentric motion right here, the contraction of the muscle. We want to make sure we focus on that negative eccentric. So as we extend the arm from this position, take about 5 to 6 seconds for that. Rotator cuff impingement is another very common injury that we see. It's really just a rubbing of that supraspinatus along the bony prominences that it sits in. If you can see right here, this supraspinatus comes right through here, and this acromion can really pinch on it, doing all the overhead repetitive motions. It can be a very vicious cycle too, because the more that this tendon gets irritated and swells up, the less space there is for that tendon to contract through. So the more it gets irritated and swells, the more it's going to rub and get irritated, and it's going to swell more, and then it's going to rub more and get more irritated. So it can go downhill very, very quickly here. Typically, it can be a combination of GERD, what we talked about before, and scapular dyskinesis. So like I said, if that inferior angle of the scapula is tilting backwards, that's just going to push this acromion right onto that tendon even more. And some congenital factors can also play a role. So we scroll back, your acromion right here might be a little bit bigger than the average person's, but with proper flexibility of the supraspinatus and good scapular control, we can get through anything. We need to assess the scapular movement, rotator cuff range of motion, and then rehab exercises are just going to follow suit with GERD and scapular dyskinesis with some extra rotator cuff strengthening. So I really want to get into the prevention aspect of it. There's a couple big topics I want to talk about preventing wise: functional movement assessments, proper arm care, training like an athlete, not like a bodybuilder, and really just listening to your body. So again, the functional movement assessments, really all it is a functional movement assessment. At the beginning of the season, we have all of our athletes come in and we put them through a wide range of different functional movements, and we look at all the joints during each movement. And then what we can see is some of these different positions that they might be in or movements that they do can put them at risk to injury. So take this overhead squat right here. When they do this overhead squat, and if this bar comes down in front of them, that's going to mean that their lats are tight. And we already went through it in the different lectures what lat tightness can do with injury. Proper arm care program. So it really needs to be a balance of scapular stabilizing, plyometric exercises, mobility, and throwing consistently. It needs to be year long, not just during the season. If you're a spring baseball player and you haven't picked up your glove until March, you might be in some trouble. Okay, you need to have the catch frequently throughout the year, even when it's cold out. You can bundle up. I'm not saying go outside and long toss for an hour in 30-degree weather, but you can bundle up and have a short catch, 30 feet. So our in-season arm care program, we broke it down into 3 different days: an A day, a B day, and a C day. So our A day is going to be a very heavy day, 4 to 5 scapular and rotator cuff strengthening exercises. The B day is 1 to 2 scapular and rotator cuff strengthening exercises combined with 2 to 3 plyometric exercises. And C day is a very low stress on the tissue day, oscillation-based exercises with bands. And the schedule is going to look like this. So we'll start on a Tuesday. We pitched in a game. We didn't do any of our A, B, C days that day. We didn't lift that day. We pitched. Wednesday is going to be our A day, and then you just have kind of like a catch at practice. B day is a little bit lighter with the plyometric exercises, and that's more of like our long toss day. C day is the lightest day, and then we throw our bullpen, which is, if you don't know what a bullpen is, it's more of like a practice pitching session where you throw 60 to 80 pitches. And then Saturday, A day, Sunday, B day, back to Monday, C day, and then we pitch on Tuesday. This program has been very successful. We see velo increases throughout the season, which is really good to see. And then training like an athlete, not a bodybuilder. Right. So this is very important. Their training sessions need to be a blend of strength exercises, plyometric exercises, and mobility exercises. It's not, go to the gym and lift for 60 minutes. All right. We have to have a blend of mobility exercises, scapular strengthening exercises, and then, we need our strength exercises as well. And like I said earlier, we need to put a large emphasis on our scapular stabilizers and our core muscles. Mobility exercises need to include lower body, upper body, and trunk mobility. And we really need to make foam rolling a regular habit. When I get to the gym, you need to foam roll before you work out and after you work out. So some of the mobility exercises that I really like that we put into our arm care program, this is just a side-lying trunk rotation. And this is a Spider-Man lunge with rotation. So both of these are going to focus on our trunk, thoracic spine mobility. Down here is a rectus femoris stretch, which is one of your quadricep muscles, but it also crosses the hip. This is a McKenzie core stretch, really good for our core mobility. I call this the hip 90-90 stretch, which is really going to work some of our deep hip internal and external rotators. Core-wise, core training does not need to be fancy. I know we see a lot of cool core exercises, that Alvin Kamara does and things like that, but it doesn't need to be like that. You know what I mean? Another thing I wanted to touch on with core is you really want to avoid spinal flexion exercises, so crunches and sit-ups. There is no point in time in our sport where we're flexing our spine. So why do so many people do crunches and sit-ups for core training? It doesn't make much sense. And all it does is apply a lot of shear force to your spine and cause back pain. Some of my favorite non-plyometric core exercises are planks and side planks, dead bugs, trunk cable twists, and barbell ab rollouts. Here's some examples of them. So here's just a regular plank. Start out maybe 5 sets of 30 seconds. If that's too easy, 5 sets of a minute, 5 sets of 2 minutes. At some point in time, it's going to start getting a little harder. You can even put a Swiss ball underneath your shin to add a bit of a dynamic balance aspect to it. Up here is a side plank. One way to make this a lot harder is just to raise this top leg up. And you're really going to target your core right here and then your adductors along here as well. Bottom left picture is an example of dead bugs. This is how we do it in the weight room. So you just have like the cable bar kind of low. You pull it over your chest, and then you're going to alternate raising your knee up to your chest. If you notice, the leg is always off the ground, kind of like in 6 inches. In the middle right here is a cable trunk twist exercise, and this is the barbell ab rollouts. Lastly, you really just need to listen to your body. Make sure to include some rest days in with your training cycle. And then if something feels sore, we need to ice it and add some extra mobility exercises to that area. The biggest thing, you have to utilize the staff around you. Most middle schools nowadays have athletic trainers. All high schools have athletic trainers at the collegiate level. Utilize your athletic trainer. Okay. At the beginning of every season, I go to everyone and I say, listen, we are here for you. Okay. We're here for you. It is our job. Like, come to us. If it's a minor ache or pain, come to us. And then that's what we're here for, just to help you out. But that is all that I have. I appreciate your time. And if you have any questions, just let us know.
Thank you, guys. Great presentation. We appreciate you taking the time to do that. Tasha and I are just going to open it up now to any questions and answers, or questions from the audience, and we'll toss it over to you guys to answer. There is a little chat box at the bottom. Actually, it's a Q&A box. Feel free to click on that icon, and there's a box that will pop up. You can write your question in right there. We'll give it a few minutes. If anyone has any questions, just type in your question right there. We will be recording this, or we have recorded this presentation, so we will send it out to everyone that attended. Feel free to pass it along to any of your coaches, athletes, parents, whoever you think would find this interesting. Again, I will go over a VIP number for all of the attendees. For Rothman, if you need to schedule an appointment with Dr. Kevin Freedman, his phone number would be 610-480-6584. And if you need to schedule an appointment with anybody from NovaCare, their number is 1-800-770-6682.
And I also just shared my
That
screen.
came over. Thoughts on heat before a game. Whoever wants to take that.
I can speak to that a little bit. In terms of if we're thinking like before a game, heat certainly isn't gonna hurt anything. You know, might feel pretty good while it's on there. The research kind of tells us that a dynamic warm up or an active warm up is going to be a little bit more beneficial in terms of both injury prevention and overall performance. Right, so an active warm up, thinking a little bit more like some band exercises or some of the exercises that Brian just spoke to a little bit ago.
Great, thank you. Any other questions before we sign off? All right, guys. Well, thank you so much for putting this presentation together. We really appreciate you taking the time, and thank you everybody who logged on. Just make sure. Yep, we're good. Thank you. Have
Hey, everyone.
a great night, everyone. Take care.
Thanks, everyone.